be trauma-informed requires that an organization recognize the impact that trauma has on everyone, not just the patient who's being served, but also on the employees in the organization. And when we understand the trauma, when we begin to think about the story, what's the story, as opposed to what is wrong with that person, we shift in the way that we approach individuals that we work with. So we look at the principles of safety. We look at the principle of choice, collaboration, empowerment, cultural competency, and trust. So as a provider, all of those terms are lovely terms that I hope that I embody. And to be able to do that at an organizational level as a leader requires you looking at your resources and figuring out how you want to be able to create a blueprint to make that change happen, so that you can be mindful of all those principles and you can figure out how to embed them in policies and in practices, and how to surround yourself with a core team of individuals that can promote this work and focus on education and training, so that everyone in an organization, not just those that come into contact with the patient, but other individuals, perhaps people in a record room or the maintenance staff, all receive education on the impact that trauma has on everyone.
It can almost feel insulting to a practitioner who's known someone for a while when a patient walks in and they don't immediately trust them. And so I think that understanding that that trust is going to have to be built in every time you interact with that patient. Otherwise, you lose the relationship. And I think when you have that ability to build trust, and you come from that perspective of knowing that the patient is not going to trust you automatically, that it's with that, if the whole team can do that in that trauma-informed process, it can lead to seamless care because the patient will trust everybody across the board. And if the patient trusts you and you trust this practitioner, the patient is much more likely to accept the warm handoff with somebody that you trust, and that it's clear that you trust them. In the best possible world, where at least one organization that provides multi-levels of care for a patient, or if there are organizations that collaborate that are all trauma-informed and keep the patient at the center, the best possible outcome is that there are fewer medical errors, there are fewer people who get dropped and through the cracks, and that people come and get their health care and don't let it go because they're too afraid to come back and not be listened to. Kind of like Pat, when it was clear in the video that she'd heard a number of times people talk about her weight when that really wasn't what was of interest to her, and that was not her priority in being there.
So have other doctors talked to you about the risks of weight?
Yeah. Yep, just about every time I go in, actually. You know, I can accept myself for the way I am, and I don't understand how others can accept me for who I am. And, you know, it's really none of their business, really. You know, people seem to judge you and think they have the right to comment on your body just because of the size that you are, you know, and they really don't have the right. People don't have that right.
So what hasn't worked in the past?
Everything.
And what has helped?
Nothing.
I was struck by Pat's response to the doctor. And as Pat was responding to the doctor, she was responding to a feeling of being historically shamed about her size. and having people make assumptions and be intrusive, and as she voiced those concerns, there was also anger in her voice as she was describing that. And as she was doing that, I was also struck by how resilient Pat is, because Pat was also able to say, I can accept myself, but you can't, others can't. So from that trauma triangle perspective, it's so tempting for a provider to look across the table and to view that individual as resistant or challenging or in denial, when in fact what's happening is that that patient is making her voice really clear and saying that that's not acceptable to me, that I accept myself and you don't. So as a provider, what role are we assuming there? Are we going to perpetrate? Are we going to continue to blame and shame her? Even on a micro level, not being consciously aware of it, because the trauma triangle is an unconscious, interaction that's happening. So are we going to perpetrate? Are we going to rescue? Oh, poor Pat, I'll just do it for her. Are we going to be the victim? Oh, yet another challenging client that I have to meet with today. So I'm feeling victimized by my client. So as a provider, what is required of us is to pause and recognize and hear what Pat is saying, and then recognizing how that is sort of triggering our own sort of narrative and that of the organization, and then find a way to break that triangle and to respond in a more conscious way.
This is what I could find of Pat's medications.
Thanks, Mrs. Chalmers. I'll take an inventory, and then I'll send these over to the pharmacist for review. I understand Pat is waiting to get in to see someone.
Mm-hmm.
Okay, we should be able to help with that. We'll schedule an appointment for her with a doctor before she leaves, and our internist will help with that transition.
Good.
Can you tell me, is there a family history of diabetes?
I thought she was here for a broken ankle. What's it got to do with it?
Well, I was just in with Pat and the physician assistant, and the physician assistant was asking Pat if there was a family history, and Pat seemed upset.
Family history of what?
A family history of diabetes. Oh. Pat said it was okay if I spoke with you about that. When she came in, we did a finger stick, which is what we do when somebody's about to go into surgery, and Pat's blood glucose levels were high. We've sent a sample off to the lab, and we're waiting for that to come back. We should know more soon.
Well, she knows enough about diabetes, that's for sure.
Can I ask you again about the family history of diabetes?
Why?
After a conversation such as that, where it might be a difficult interaction, it might be a little uncomfortable, because I think, she's not used to being asked those questions, that for that particular nurse to go back and say, I had a difficult conversation with a patient's mom, and I was really trying to help her to be part of the patient's support team, but it didn't come off that well. And just wondering, what could I have done differently? So that there's that vulnerability for learning and for making it okay to either make some mistakes or to not get frustrated and just blame the patient for the problem.
Trauma-informed organizations that set aside time for self-care are providing that opportunity for staff to feel safe. We're hearing stories, we're being present to individuals that are struggling in a variety of ways, and being present to that time and time again begins to wear down our resources, which is why self-care is so important. And to truly be trauma-informed requires that one sit as a provider and look across the table and begin to wonder, there's a story there. I may never know the entire story, I may not need to know the story, but understanding there may be a reason why that individual is working the way that they're working. And when we think about that scarcity model, if this is an agency who feels under siege and has limited resources, that provider sitting at the table is operating from that framework. And when I think about staff, I'm thinking about everyone in the organization, not just those that are on the front line providing that clinical patient care. So thinking about training and education, and ways to promote continuing education so that staff feel valued, that knowledge is important to the organization, that we know that the field is constantly developing, so we want to stay on top of that. So learning about that, and then looking at ways of engagement. So how are we engaging? What does the physical facility look like? Is it a warm and inviting facility? And that speaks to safety. Robert Anda, the co-principal investigator of the Adverse Childhood Experiences, spoke several years ago about trauma-informed practice and what would a trauma-informed community look like. And he coined this term, healing community. It would be a healing community. So at every level, we would, whether you are in a school, whether you are at a university setting, whether you work at a bank, if you are a healthcare professional in a hospital, that everyone would recognize and understand the impact that adverse experiences have on our health. So when we think about social determinants of health and we think about those adverse experiences that impact our health, having that knowledge, having that awareness, looking at prevention as well as treatment in that collaborative way results in a healthy community so that everyone is part of that medical neighborhood, not just those individuals providing the healthcare services. But when we think about the system of care, everyone who touches the life of that child or that adult, we all become part of that healing community.